Are you pregnant or a new parent looking to ensure a better postpartum experience? Or are you a birth worker looking to improve your postpartum care skills? Check out Thriving After Birth, an online self-paced course by me, midwife and educator Tanya Tringali. It's 10 and a half hours of video content featuring experts in lactation, mental health, pelvic floor health, pediatric sleep issues. You also get worksheets and a workbook, as well as options to have a one-on-one session with me. Sign up at motherwitmaternity.com/thriving, and let's improve postpartum care together. Welcome to episode number 10 of the MotherWit podcast. Oh, and a gentle reminder that nothing we discuss on this show should ever be considered medical advice. Please speak to your local provider about anything that comes up in this show that resonates with you and your needs and your health care. My guest today is Lisa Paladino. She is a certified nurse midwife and has been so for 28 years. She is also an IBCLC, International Board Certified Lactation Consultant, and she's an expert in tongue tie, which you will soon discover for yourself. Lisa, thank you so much for joining me today.
It's a pleasure to be here, Tanya.
Okay, so before we dive in, I would love it if you would tell our listeners a little bit about your background, because you, I think, have a very unique background as midwives go.
Yes, I am a midwife and a lactation consultant, and there are a few of us who are both CNMs and IBCLCs. It's growing, but it's still unique. So I worked for many years, 28 years in the hospital at the bedside. And then I gradually continued my education from a nurse RN to a CNM, got my IBCLC along the way, did some public health projects while I worked at the hospital, worked at on the Baby Friendly Initiative in New York City for many years while I worked at the hospital. And I was in the position of lactation consultant, breastfeeding initiative coordinator, and midwife catching babies for 8 years at the hospital. And then I just had enough. And I said, you know what, I can do this better on my own. I can do more things on my own. So I left the hospital 6 years ago now. And I'm in private practice. I'm in Staten Island, New York. And my focus has gone to a place where I never expected it to be. So because of a need, I have made my niche tongue tie. And it's nothing that I ever expected it to be, because I didn't even learn about this in school. And you'll hear me say this often, we don't learn about tongue tie in school. So I had no idea where it was heading, but that's where it is. I say that my practice is a little bit like kind of split personality, because on the midwife side of my practice, I'm still practicing with women as a midwife, but in functional medicine. So I have taken a lot of functional medicine courses. I'm a graduate of Dr. Aviva Ram's Functional Medicine for Women course and her herbal course. And I help women with hormonal imbalances, which sometimes ties in nicely to breastfeeding women who are having problems with milk supply and things like that. So that's where I am now.
Well, I think, Lisa, one of the reasons I've always been so fond of you is I think we're on kind of similar paths. I'm a little like behind you in terms of, my years of having left regular clinical practice and all these things. But in doing the postpartum work that I do, I say the same thing all the time. None of the stuff I'm doing is what we learn in school. Like none of it. The 6-week postpartum visit, I know I'm beating like the same drum, but that's just not enough. And I've learned all of these other things. So it's always so interesting when I meet other midwives who have kind of carved a really unique path for themselves. And then just for our listeners' sake, I want to actually mention Aviva Ram for a moment and say that, clients who have worked with me, anyone who's worked with me, I have sent them something from Aviva Ram. Because she's great. Her work is fantastic. And I kind of really enjoy telling people her history, right? Like, I can't remember what midwifery conference I was at when she had recently become a Yale trained, is it Yale? Yeah. Yale trained physician. And I was like, oh my gosh, this woman has gone from being like a teenage lay midwife to a CPM, to an herbalist, to a doctor. Like she kind of blows my mind, and she's so smart. And I'm so thrilled that you're.
Yeah, she's my mentor now, my friend. We've done some work together, and it's always an honor for me to consider her my friend, because what she models, and like you said about sending information from her, I just did the same thing today. Like, it's almost like, why should I bother making something? I can just refer, because Aviva has so much there. And yeah, she's a wonderful woman and a wonderful human in what she gives. She's so much of what she does is free, you know, for the public, and which is amazing, sharing all her knowledge. But you know what, Tanya, I just wanted to go back to what you said about the 6-week postpartum checkup, because I bet you feel this way too. Like when I was practicing regular midwifery, as I call it now, I feel like I was failing my patients. Like I feel when I look back at things I missed, I mean, I know I missed things about lactation and tongue tie, but when I realized, not exactly from fault of my own, but just because there was no room in the system of how my patients lacked the care that they deserved, because I didn't know what else, I didn't know what they were missing, you know, and that's why I love working with you and associating with you. And, you know, I recommend your program, because I know that you're giving that missing piece that every birthing person deserves. You know, it's really a shame that everybody doesn't get this care.
Well, and you just hit it on the head why I started this podcast. And that is because I really wanted to create a space for clinicians and clients to find common ground on why we sometimes fail them, and the ways in which we are trying to be creative about filling gaps and solving problems. And it's not any one individual's fault. It's an enormous systemic problem. And I think some of us are better at staying within the system and fighting. And thank God for all those people who do. I couldn't do it anymore. But at the same time, what we're out there doing comes with all other sorts of burdens. And you're willing to take on what you're willing to take on. And it is what it is. But yeah, I hear you on all those points. Okay, so for our listeners' sake, once again, if you didn't listen to last week's episode when I interviewed Erin Khan, I highly recommend going back and listening to that episode for some context, some real life context of a real client's struggle with tongue tie. I'm very intentionally positioning this episode to follow that episode so that this isn't just a bunch of information that doesn't come without clear rationale for why you need this information. And Lisa is, in fact, a tongue tie expert. That is her website, tonguetieexperts.net. And I'm sure we'll tell you more about all of this shortly. But so as we get started, I just want to lay some groundwork for everyone. Can you start out by defining tongue tie in clear layman's terms, lay person terms, so that everybody's on the same page?
Absolutely. So a tongue tie has to do with the frenums in our mouth, right? So we all have what's called a frenum in different parts of our oral anatomy, and probably in other parts of our anatomy too. So there's a frenum normally that holds things together under our top lip, under our bottom lip, under our tongue. And they're supposed to be there. But sometimes they're either too short or attached in a place that makes normal function and movement difficult. So frenums in their own sense, there's nothing wrong with them. But if the movement that they're supposed to do is interfered with, then it's a tie. So in other words, if there is a frenum under the tongue that's too short or attached too far ahead in the mouth, too close to the tip of the tongue, or as I said, too short to prevent functional movement, then it's a tongue tie. If the lip frenum is too short or too tight to prevent the lip from flanging up or being able to move up comfortably, then it's a lip tie. And some people even refer to what we call buccal or buccal ties in the cheeks, where, you know, it might look like a cute little dimple, but it's actually going from the cheek to the gum, and it's holding it in place and not letting the face open up enough to get a nice open latch. So that's the definition by.
So with the buccal, where does it attach exactly? Can you?
It's so hard without
feeling
seeing
around my mouth, trying to.
Yeah, it would be upper, and it would be like very close to where the gum line before the teeth, like over where the teeth would go. And it would, and it's usually towards the front. It's usually like right where like your eye teeth are.
Uh-huh. I got
Right.
you.
So some babies can't open their mouth at all. And it's more than just a lip. They don't have enough room to get their whole upper lip up, even when that front lip tie is released. But that's getting into, you know, most babies don't have a buccal ties, but it's something to think about. It's something to think about. But it's the lip and the tongue, the upper lip and under the tongue, that are the most common.
Are you able to say at all what percentage of babies have ties? Because I'm sure the data is pretty crappy on this front, but like best guess?
So the latest research I saw said 25%. A couple of years ago, we were saying 5%, but that was because so many babies were being missed, right? Now, it's really hard for me because I only see babies who are having problems. So I rarely see a baby that doesn't have a tongue tie. I mean, I do, but rarely. You know, usually they're coming to me for other problems, maybe mom's milk supply or something else going on. But it's, so I have a skewed set of data, and most providers do as well, which is why it's hard to get that exact number. And then there's the controversy of, is it being overdiagnosed or is it being underdiagnosed, right? And I think that both are true. You know, as a midwife, I'm non-interventionary. Like, I don't want to do things that we don't have to. And I pretended that this wasn't a thing for like the first 6 months of my lactation practice, because I couldn't imagine that we had to do something to newborns to help them breastfeed. I just thought that was ridiculous. And then I had a bunch of babies in a row that I couldn't help with my usual lactation skills. I couldn't help them with everything that I had learned as a nurse, as a midwife, and as a lactation consultant even. There was very little knowledge of tongue ties 10 years ago, 11 years ago, when I was studying for the test for lactation. So I got a little info about tongue tie, and then I just went down the rabbit hole because there are organizations dedicated to this, networking organizations. And I started going to meetings and getting education. And all of a sudden I realized the babies I had missed and how I had you know, I don't want to say mistreated, but technically, yes, mistreated by not pointing this out. But at the time, I wouldn't have even known what to do about the tongue tie, you know, who to send them to and what the best care would be.
Do we know anything, you know, in the scientific literature about why so many babies have tongue tie, like from a physiologic or a genetic perspective? Is there anything out there to explain this?
So the theory that I like the best is that it's an epigenetic change. So it's not just what our genes, as you know, we have genetic code, but we are not just our genes, we're how our genes express. And the theories are that for so many generations of infants that weren't using their jaws, weren't using their tongues to breastfeed, and those genes have turned off. When you start going down the rabbit hole, as I described, you run into research about this is more than just about breastfeeding. This is about how the mouth forms, and our function and form of our mouth for breastfeeding is just the first function, right? So when we realize that, and then we start thinking of other things, and there's research, there's a couple of different scientists actually who have looked at skulls before the Industrial Revolution, when babies were breastfed and then just fed grown-up people food that was chewed for them, or grown-up people food that they had to chew as soon as they could. No baby food, no soft food, and there is no malocclusion. There are no crooked teeth. there is nothing wrong with the airways. There probably wasn't sleep apnea. And I know we don't want to get into all this, but these are all modern diseases, right? Nobody needed braces in the Stone Age, right? I mean, there weren't braces, but they wouldn't have needed them because their teeth were straight. And that when you realize that the way the tongue functions forms the whole oral cavity, you can make that connection. And also where the teeth are and things like that. So it's more than just breastfeeding for sure, but we don't want to go down that rabbit hole. We want to talk about your patient's experience and what could have been done different. What we can learn from that.
Yeah, I mean, nonetheless, that's one fascinating rabbit hole. I'm kind of digging it, but yes, we're going to stay on task here. All right. Yeah. So in staying on task, can you tell us a little bit about the symptoms that a lactating person or their baby might commonly experience if things aren't perfect and what they're having is tongue tie?
Yeah, so I like to divide the symptoms, and I say there's signs and symptoms to get an evaluation. None of these signs and symptoms will tell you it is absolutely a tongue or a lip tie. And the tongue and lip tie symptoms overlap. And another fact is that if there's a lip tie, which usually is the easiest thing for parents to see, 95% of the time there's a tongue tie that the parents don't know how to see. So that's something that can be helpful. But the signs in an infant is nursing a lot and never seeming satisfied. That's one of the first symptoms if they latch at all. So a baby who cannot latch should be checked for tie. A baby who latches but doesn't seem to swallow, just lots of sucking or seems like they're nursing. A new parent may think the baby's doing fine, doing lots of nursing, but they're never, ever, ever satisfied. They never get that like relaxed after a feeding aspect to them. They may lose weight, right? Sometimes they gain weight really fast because they're just catching milk if mom's got a great milk supply, which can be tricky, right? So any extremes I would look at. Reflux or spitting up, because as they're swallowing, if they have a pore seal on the breast, they'll be taking in air. And the tongue and lip tie do cause a pore seal on the breast, which brings us to signs and symptoms in the lactating parent. Definitely pain, but not always. Like I had someone in my office yesterday who was a second-time mom, and her baby is having lots of difficulty with latching, but there's no pain because she was still tandem nursing her 3.5-year-old, and her nipples are just used to breastfeeding, right? So pain is definitely, if you have pain, that's definitely a reason to get checked out. Of course, cracked and bleeding nipples come with after the pain. Vasospasm can be related to tongue tie because your nipples are literally being chewed on, so they're becoming more sensitive, and that sounds awful, but it's just the fact. What other things? Later on in the relationship of breastfeeding, a baby who seems like they were doing fine, but all of a sudden they drop off the curve. Mom thinks or parent thinks everything's great, and then all of a sudden she feels like she has no milk supply. That's usually about 3 to 5 months because the hormonal driving of the supply goes away then, and it's more of an endocrine pulling of the milk out that makes the milk. And if the baby's not sufficiently taking milk out, the supply will go down. What else? Misshapen nipples after feeding, either flattened or lipstick shaped, or with there's a smile shape that comes like in a mark around the bottom of the base of the nipple sometimes when there's a significant lip tie. Babies who have lip tie often have a lot of blisters on their lips because they're holding on with their lips, and that's why the mom has that little shape of like a smile around the base of her nipple from the baby holding on so tight there. I'm going in all kinds of circles. I didn't go down my list, but there is, I do have a link, and I know you're going to provide it, to the signs and symptoms of tongue and lip tie in the parent, in the baby, and in the feeding, because I feel like we have to look at all three aspects there.
Yeah, so listeners, this will be in the show notes for sure. This is a really helpful document. And listening to you, I have one question. When you talked about the smile, are you saying it's like a little bit of like a indent almost in the shape of a
Yeah.
smile? And you're saying that's on the nipple itself, on the underside, or like, tell me.
It could be on the underside. It could be anywhere around the nipple.
Okay.
But it's usually not all around. It's usually like a, but that's, that's not any pain. They're going to have pain. So they don't have to be like looking at their nipple to see if there's a smile shape there.
Yeah.
But a lot of times that's the first place where you'll see the breakdown.
Yeah. No, I wanted providers to hear that because I almost feel like I can picture having seen that, but didn't have any context for necessarily what I was seeing. Those of us who are midwives but are not lactation consultants, when I listen to your list, what I realize is that I actually know a lot of these now. I didn't know every single one you said, but that's because I'm doing this very specific postpartum work and I work really closely with a bunch of lactation consultants now. But back in the day, before that was true, I probably knew less than half of that list. And I certainly didn't know what to do about it besides refer someone to get it treated, right? So we're going to talk a little bit more about that referral process here in a moment. But before we go there, and you kind of touched on this, I feel like when you mentioned babies getting diagnosed with reflux. But I feel like in a world where a new parent might encounter providers with vastly different beliefs, and I hate that I even have to use the word belief about something like this, but vastly different beliefs, we may see a number of additional diagnoses and or misdiagnoses. Can you talk a little bit about this, even if it's from an anecdotal perspective and not necessarily, a perfect list of what parents who maybe have had some of these problems and are maybe hearing themselves in what you're saying might have been told by providers is what's going on with their baby instead of tongue or lip tie?
So unfortunately, it's more than anecdotal. I mean, there are so many missed tongue ties that my most popular post on Instagram is, who has missed your tongue tie? Who missed your baby's tongue tie? And the answers I get break my heart, of people whose kids, like from the smallest problem of pain to the hardest problem of baby needed a feeding tube. It was so bad, and nobody looked for tongue tie. So anytime a breastfeeding parent is having such difficulty that the infant needs to be supplemented, there should be a lactation consult with that supplement, right? And they're almost, like, I'd say 90% of the time there's not. So pediatricians, and you know what, I hate to diss doctors, but I'm going to say this, and I say this proudly, pediatricians have to understand what they don't understand. So if they don't know how to help, supplementing with formula is not the answer. That's a Band-Aid on it. So I have so many babies, both in my practice or that I hear about through my social media accounts, because now, you go out there with tongue tie experts as your name and you're going to get the stories, and it's pathetic. Pediatricians should never tell a parent to supplement and not look for the reason that breastfeeding isn't working. Right. And I think that's the message that has to get out there. The other thing is reflux. We're so fast to prescribe medication for these tiny humans without saying, why is this baby having reflux? And there are so many similar or overlaps of symptoms with reflux, tongue tie, and food intolerances. So we also have babies who are being taken, the parent can't eat anything except like whatever, white rice and boiled chicken. And, and the baby has a tongue tie. That's why the baby is having explosive poops, which is one thing I didn't mention in the list, because that aerophagia, that swallowing of air that causes the reflux, can also cause explosive poops. And I have also seen green poops that we consider as a food intolerance, but that can come from tongue tie as well, just because some babies swallow so much air. So I've seen all of that go away when the tongue tie is treated.
What about occasional blood, and also a stringy appearance in the stool.
Yeah, this gets so tricky because, you know, there are some kids I think that occasionally you're going to have something, but blood makes me nervous, and blood is usually a food intolerance. But occasionally funky looking stool, occasionally doesn't make me nervous. I would always say, always ask a pediatrician. But to me, we're always allowed to have a one-off bad poop, you know. But if it's regular, it's something to look into. You know, food protein allergy is a real thing in kids, and it seems to be, you know, growing more. It's never a reason to stop breastfeeding, but it's also a reason to make sure that it actually is that, and not tongue tie, or not tongue tie coincidentally at the same time, because they can coincide with each other, you know. Yeah, so that's what I would say. And the other thing that I would say is the most important thing, if, you know, for parents who are listening, is the most important thing is to learn to advocate for themselves, and to realize that your pediatrician is not in charge of your baby. You're in charge of your baby. Your OB is not in charge of you. Your midwife even isn't in charge of you. And I tell, even your lactation consultant, I tell this to people in my office all the time. If you don't feel like what I'm telling you sits right with you, then don't listen to me. You know, follow your instinct. If you're not getting the answers you need, move on. There's so many pediatricians. I used 7 pediatricians for my 3 kids, you know, like, till I found the one that would just like leave me alone the most and just be there when I needed her, you know. Pediatricians do not learn a lot about breastfeeding unless they take extra courses, and they certainly don't learn a lot about tongue tie or even nutrition, you know. So, and a lot of baby care recommendations given by pediatricians just based on their own experience, not by what they learned in school.
You know, I think a lot about IBCLCs as an adjunct to pediatricians in the same way that I think about pelvic floor physical therapists as an adjunct to midwives and OBs. And they are both just too commonly underutilized because the pediatrician or the OB or the midwife don't either believe, I have air quotes going, believe in something, or they don't want to face that they don't know how to fix this other thing, right? So whether it's something going on with your pelvic floor that is entirely out of the scope of a midwife or an OB, we do not go to school and learn how to fix muscular problems in the pelvis. That's not what we do. We know what healthy tissues look like. We might be able to diagnose a prolapse or urinary incontinence, but we don't learn how to treat it. And we don't tell patients what we don't know. And the pediatricians don't either. And for the life of me, I cannot understand how it is that pediatricians set up practices that don't include a lactation consultant. Like, how is it that a newborn goes to a pediatrician's office and it doesn't also involve a lactation visit? How is that possible?
Right. So one of the empowering questions that I like to give to parents, and this is why I don't get I don't get recommendations from my local pediatricians, because I'm very New York, let's put it that way. I say to them, you should ask your pediatrician, if it's not a tongue tie, why do they think breastfeeding isn't working? Right? Because there's got to be a reason. It's a biologic imperative for your baby to feed at the breast. Now, that's not going into societal norms, or, you know, I'm not dissing formula feeders or bottle feeders. That's a choice. But biologically, we have an imperative to feed at the breast. It's the first function: suck, swallow, breathe. So if that's not working, why do they think it's not working? And what can we do to fix it? If it's not tongue tie, then what is it?
Well, let's take this one step further also, just so that we make sure we're being inclusive of all choices of how to feed babies. I believe there's a rationale for, even if you say, I can't do this anymore, I don't want to do this anymore, I didn't want to do it in the first place, whatever, a baby that presents with these symptoms, even if they're not going to breastfeed, there are reasons to still get this evaluated and possibly treated, correct?
Absolutely. And also some of these symptoms occur with bottle feeding as well. And some, a lot of the babies that come to me at the point where they're ready to be introduced to a bottle and they can't take a bottle. So that's another interesting sign or symptom that's been popping up for me lately. And it's strengthened my relationship with the speech language pathologist who's a feeding therapist in my area, because this is teamwork. And we'll talk more, but I hope we get to the teamwork aspect of this. But some babies can handle the breast and they just can't do anything with a bottle. And that's another sign that there might be an oral restriction somewhere, right? So they have to, it's not just about breastfeeding. The other things that can come up for kids is whatever function is their age level. So in the beginning, it's feeding at the breast or on the bottle. Then it can be solids. So there's some kids who get to the solid stage and can't handle solids. Then there's also when speech and language starts to develop and can be a problem. Now, that doesn't mean that every kid who's got any kind of tongue tie is going to have a problem with speech. There's no way to predict that, but it's something to, if a kid is having a problem with speech, they should be evaluated for tongue tie, just to make sure it's not that. And tongue function, not only just tongue tie, but tongue function, which is a whole, you can find SLPs that'll chat with you about all those controversies, because there's lots of that too.
We hope you're enjoying the Mother Wit podcast. If you are, please rate us and leave a review in iTunes, Spotify, or wherever you're listening to your podcast. Thanks so much. Now, back to the show.
Okay, so since you've introduced this idea of a team, I want to start by asking you, Erin Khan in last week's episode, this is a quote from her: "Don't just Google a provider. That's not the way to do it." So what is the way to do it? How do we find qualified providers?
So when I have courses for both parents and professionals, and in both sets of education, I teach about that this isn't just something, you just don't go get your tongue tie clipped or lasered. This is a team approach. And most babies that I see, I don't send directly to the pediatric dentist. I send usually for some sort of body work first, unless it's an emergency, right? So somebody to make sure that this baby is ready for it, or that the oral restriction isn't appearing to be an oral restriction because the baby has tightness somewhere that's pulling that tongue back. So when you know that all the muscles of the head and neck are attached to the hyoid bone, which in turn is attached to the tongue. So if there's tightness in one shoulder or in the cervical spine, and the baby can't, articulate or move in every direction comfortably, it may be pulling the tongue back and appear to be a tongue tie. So if we can get some body work going, and that could be, depending on who's available, chiropractors, in older kids, it's myofunctional therapists, speech language pathologists, occupational therapists, osteopaths, craniosacral therapy providers. There's no, OTs. I hope I'm not missing anyone. There is no absolute, it should be this provider for this baby. I like to say there should be a team of people that the lactation consultant you see refers to and trusts, and then you go with, who can I get an appointment with? Who can I afford? Who is most accessible to me? And that is usually how we talk about that. And then usually the communication between myself and the body worker will, and how things are going for the parent, will give a little bit of like an idea of, now it's time to do it. Or maybe we don't have to do it, but we can watch and wait before we send on to the provider for frenotomy. And if it's a pediatric dentist who is trained and understands the team approach, they will want this first, because they only want to do the procedure on babies who definitely need it. Because if here's what I like to say, if there's a tongue tie there's so many times there is a tongue tie there, but we want to make sure it's the tongue tie that's causing the problem and not just anecdotally a tongue tie there. So the evaluation by the IBCLC is critical. Sometimes I've had parents in my office that honestly don't even know how to hold a baby to nurse. And once I do some position changes and get the baby closer and get the baby's mouth open a little bit, everything's fine. You know, even though it looks like there's a tongue tie there, when we could find one if we want to, we can get things to be okay. And then that will proceed. So you don't want to just run and get this done, quote unquote.
And so you just made such a great case for both our clients listening and our midwives listening as to why kind of the order of events is critical. We as midwives probably should not say, oh, that baby's got a tongue tie, go get it treated. We should say, you need to see a lactation consultant who we trust to continue the evaluation of tongue tie, because just because it looks like a tongue tie and acts like a tongue tie doesn't exactly make it a tongue tie, right? We need that next level of expertise to try all the things, all the tricks before we go down that road. Is that what I'm hearing?
And then, yes, and even if the procedure is necessary, we want to have the ultimate setup for it. For example, I had someone in my office this week who had the procedure before she saw me. And there were things that I can't fix because we should have done them before. You know, I mean, yes, we can improve it, but this baby wasn't latching before because mom was so uncomfortable. So now that the baby had the procedure and the baby got some discomfort from the procedure, why would the baby all of a sudden say, hey, mom, now I want to breastfeed? It's not happening. We have to learn, we have to teach that baby to come from the bottle to the breast. And only a lactation consultant knows how to support that fully, you know, especially if a baby's fully bottle fed. And, you know, balancing milk supply. I've had parents who have very little milk because the baby hasn't been extracting the milk and they haven't been pumping. And we don't want to do the procedure and then hope that that gets her milk supply up. We have to work to get her milk supply up concurrently and hopefully before we do the procedure. So there's a balance of when it's the right time, you know, and
what I'm hearing you say there is, again, just doubling down on making this point. When we skip the lactation consultant and go right to the ENT or pediatric dentist, which we're going to talk about in a second, we miss the opportunity to solve the other problems that are concurrently going on or that may be made worse by the existing tongue tie. So whichever it is, we're missing opportunities. We're letting valuable time pass where someone's milk supply is dwindling, et cetera, et cetera. So I think this is extremely helpful, logical progression, a sequence of events for both consumers and healthcare providers to really buy in on a strategy for how to help people. This is really great. Okay, so I just mentioned ENTs and pediatric dentists, and I think clients are super confused, and I think midwives and other professionals who work with people in the perinatal period maybe don't understand it either, including myself, to be honest, and just kind of roll with it and go, that's just who does it. So what's the story? What's the difference? Is there a difference between seeing an ENT and a pediatric dentist in your experience? What should we all know about this?
So that's a great question. And so I like to explain it this way. You don't want to go to someone who says, oh yeah, I know how to do that. You want to go to someone who this is what they do, right? So if there are ENTs who have made this their business, this is what they do, they've gotten education and they do a great job. But in general, most ENTs won't do the lip tie. I find it rare because they don't think it's necessary because they don't understand it. And again, if there are ENTs listening, or if you know an ENT who does this right, I'm not trying to insult anyone. It's just that in general, a pediatric dentist has had special training, hopefully, has a better tool than the ENT, right? And my personal preference is a CO2 laser, which is a specific type of laser because there's less trauma to the tissue, it heals better, there's very little bleeding, and it seems to have a more complete release. You can get a deeper release than with a scalpel or a scissor. And that being said, there are some providers who are very good at using a scissor. So it's more about the provider than the tool. But the other thing that I like about sending someone to a pediatric dentist is I know that there's specific brands of lasers where a lot of education comes along with getting that laser, and networking and understanding the importance of an IBCLC and body work. And I know that, full disclosure, because I've done some lecturing for the laser company, and I'm proud to be, you know, I've gone to their conferences, and I've lectured for dentists on the importance of this. And you know, that piece of, do we refer right to them? They shouldn't want us referring right to them. They should want this child to have been fully evaluated so that they know that they're getting a patient that needs the procedure. Because if we consider this a functional problem, just looking and seeing it doesn't tell us if the function is working or not. And that's what they do, right? They look, they're not going to evaluate a breastfeeding.
Have you actually worked with a pediatric dentist who will say to a patient who calls, oh, you haven't seen a lactation consultant, I need you to do XYZ first?
I know of a couple who do. You know, it's hard, and I don't blame them for not, because this is the answer I've gotten from a couple of them. When a parent is desperate and they, you know, they have a lot of pain and they can't latch and they know that this is the problem, they feel badly turning them away, right? So this is a gray area, and this is within the tongue-tied community. It's a kind of another little controversy. You know, should they or should they not say, well, you can't come to my office? I don't know.
Listen, that's a really fair and balanced answer. It was just
Yeah.
a question that came to mind, because I was like thinking about, you know, I get a little overly organized in my thinking sometimes. And as I was getting super excited about this like way of approaching it for clients and for midwives, I was thinking, all right, well, then everybody in the process needs to be on the same page. And, you know, I think you're right. It makes sense that they wouldn't turn people away, but I hope that they at least say, now you need to go.
Yeah, they do. And I've had, it's so funny because the dentist that I refer to mostly will send me a letter afterwards about my patient, you know, like this is what we did. This is what we found. This is what we did. We collaborate that way. And I get letters from people I haven't seen, because they'll say, oh yeah, I went to Lisa and I've never met them. Like, are you kidding me? You know, like, or they plan to come to me, so I get the letter, you know? So yeah. And the other thing to say is there are some kids where this is a simple fix. It's just like, okay, we'll do it and everything feels better and everything goes well. There are some kids where that's the truth. And then there's others where it's an entire process that takes months.
What you just said speaks to me so thoroughly, and it explains my own pendulum swing experience, because I will never forget that as a young midwife, the first few times I had someone get the tongue tie treated and I saw what appeared to be a miracle, it makes you just think, this is what it always is, when you don't know all the other stuff. And then of course I had my first experience a long time ago of somebody who it made not a single bit of difference in, which is, you know, the story of Erin on the last episode. That first go round, no relief whatsoever. And I was like, well, incredulous, like, how could that be possible, right? So then you move into this whole idea, like, you know, Erin said, this is another Erin quote from the show, it's not just snip, snip, done, right? And so can you explain a little bit more about why it's not just snip, snip, done, and talk a little bit about what we do around the edges of snip, snip when it's the right thing to do?
Yeah, absolutely. First of all, we can free the tongue, but if the tongue is a muscle. If it doesn't know how to work, it's not going to automatically work just because it's free. So we have to train that tongue to work. Now, in some kids, that's real simple. Just breastfeeding does it. Some kids latch in the dentist's office and it's heaven from there on in. And other kids do okay in the dentist's office, and then they go downhill and have some bumps along the way. So what I like to do is teach parents to be prepared that it's not going to be a quick fix, so that we try as best as we can to get the baby functioning in ways that we're teaching the baby to use their tongue. So that involves body work, like I talked about the body work, getting the baby's body ready for this change. And then also exercises, right? So when the baby has the tongue released, hopefully there'll be stretches prescribed by the dentist, because getting a little geeky, we want the wound to heal by secondary intention, not primary intention, which for lay language, that just means we don't want it to heal back where it was. So if you get a cut on your finger, you want your finger to look the same afterwards. Here, we're making a new place for it to heal. So that's important, because we don't want it to close up quickly. So there are stretches to be done to keep that wound from closing too quickly. That could be difficult for parents, and it's overwhelming. So I like them to learn that before the procedure, so that they get used to touching inside their baby's mouths. Maybe not stretch, but at least put their fingers where they have to be, and them and the baby get used to it. Then the other thing is exercises to get the tongue moving, which is one of the pieces that sometimes the dentists drop the ball on, or the ENT. Most ENT, again, I hate to diss the ENTs, but there's one ENT that's that knows what he's doing, that's very popular. But in general, ENTs will not prescribe anything. They just think they did their magic and everything's okay, which might have been what happened with your client. And then, so the stretches and exercises are two different aspects. And sometimes the overwhelmed parent, I don't blame them, forgets to do the exercises and just focuses on the stretches. And now you've got a kid where every time you go into their mouth, it's uncomfortable for them, makes the parents stressed, and there's no fun or playtime in the kid's mouth. And that's not good for anyone, because now the kid doesn't want anything in their mouth. So if this isn't handled well, one of the extreme complications is oral aversion, which thank goodness I don't see in my practice, because I prepare everybody, but I have seen it happen in other practices. So it's important to learn simple exercises to do to get the tongue moving, and start them before the procedure, and do them in playful ways, separate from the stretches that are going to cause discomfort, and playing with the baby. Make it a game, make silly faces and, raspberries and all the things that parents do. It's gotten very hard for me to demonstrate the exercises in my office with a mask on, but I get creative and the kids can see me happy behind my mask. So that's why sometimes it's not a quick fix. Also, some kids will reattach, and we can't really predict which kids will reattach. And it's easy. Some people say, oh, it's because the parents didn't do things right. It's not necessarily that way. And I learned that lesson because a really good friend of mine, her baby, who's now like 6, had the procedure done. And I was helping her with both the stretches and the exercises. I saw her do it. We socialized. I made trips to her house. I did them myself. And one day she woke up and the kid was nursing like she nursed before the procedure. So what did we do? We sent her to the chiropractor. And then she had some CST. And she didn't have to have the procedure again. Everything relaxed and opened and everything was fine. So yeah, it's unpredictable. There's a whole school of thought that babies don't feel pain.
Is it worth it?
And
yes.
I'm not in that
question
school.
I get. Is it worth it? I think it's worth it. But it's also something
We know from the adults
not
that
to
have
go
had
in
this
blindly.
procedure,
not to go
this
in
is very
unprepared.
painful. Very painful. Now, usually it's a bigger procedure on an adult, so the pain is probably amplified, and kids do bounce quicker than grown-ups, but it's uncomfortable and you could see their pain and the stretches are uncomfortable. So we have to have a way to mitigate that pain before the procedure happens. So I have a whole checklist in my course for parents all about what you're going to do that night, what you're going to do before, so you have it ready that night. And one of those things is talk to the doctor doing the procedure and decide ahead of time what they recommend. Have it in your house, right? We like breast milk ice pop, so you can put some breast milk and freeze it and use that. There are some homeopathic remedies that some dentists are hesitant to recommend because homeopathy is controversial again. So many of the things I mentioned are controversial, but homeopathy does work. And I've used a homeopathic mixture and given it to grownups having the procedure, and they didn't even need to take Tylenol. So we know that it works. There's a myth about that the actual laser makes the nerve endings go away and it doesn't hurt. That's not true. I don't care. I'll go up against anybody about that. You can see that this is uncomfortable for kids. And sometimes when kids are uncomfortable, they shut down, especially newborns. They shut down. They don't cry. They just shut down and they look like they're sleeping, but they're really, you know, that sleepy state of I'm not here and I'm going to look like nothing's bothering me.
Well, that makes perfect sense actually, because any midwife has seen someone disassociate from their body in labor, especially people who have history of abuse and things like that. So, you know, why would we not just leave our bodies if we could?
And newborns can. So, so as far as how to find a provider, I think you're going to link in the show notes to questions to ask a provider. It's very important that a provider has a team. If you ask a provider, do you have a team that you recommend? Are there lactation consultants and body workers and SLPs that you work with? And they say, I don't know what you're talking about, then you want to run in the other direction. Because anyone who knows what they're doing and has invested enough education into understanding the team approach will be the one that's doing the right thing. Because I'm going to tell you a little secret. I know it's not a secret, it's going to be on a podcast, but a lot of dentists learn from IBCLCs because we go to the office and say, you know what, you released this much, but the baby needs this, or that baby that you did should have been a little bit this way, you know, and if you have the right relationship, you learn from each other. So if there's no networking there, then you don't want to be going to that doctor. You want to ask them how you're going to get in touch with them, how many procedures they've done, when do they want to be called, do they recommend anything for pain? So all the questions that to be asked are on that handout that they can get for just by downloading it.
And so on that note, who should consider your course, the one that is for clients and the one that's for professionals?
So as far as parents, anyone who's, anyone who has a suspicion that it's tongue tie, through my baby's having a tongue tie and I can't find the right IBCLC to guide me, because not all IBCLCs have learned about this, right? So through that scope, and there's sections, there's a complete course, and it's all very affordable. The parents course is really affordable. And if you already know that you have the tongue tie and you're going to have the procedure and you just need guidance, then the second half is just about how to prepare, what exercises to do. There's handouts, there's videos, all about the exercises and the preparation, questions to ask and things like that. How to be ready that night, down to have meals ready. You don't want to be coming home with a baby who's a little upset and trying to figure out what's for dinner, So I get very practical and granular with my recommendations for the night of the procedure and what to do if the baby's not latching, things to do to calm yourself and calm the baby after the procedure. And as far as professionals go, I think everybody should take my course, and it's for anybody who has any contact with with pregnant or breastfeeding families. Lactation consultants, with all initials. There's so many different initials, CLCs, CBSs, anybody who is a lactation person at all. Nurses, Lord help me, doctors would be welcome. Dentists, and I have had some dentists in my course, body workers, childbirth educators, doulas, midwives, anybody who has contact with the dyad or the pregnant family should understand at some level. And my course is meant to be generally introductory and also go into, if it's in your scope, do this. If it's not in your scope, guide them because the lactation consultant is going to be doing this kind of thing. So it's multidisciplinary on purpose, because one of my missions is to stop the education in silos. We learn so separately. And I think that's part of what attracted me to the field of tongue tie. When I went to my first conference, and there were professionals from all of these areas respecting each other in a way I've never seen, not at the hospital, not at any other conference. We all learned separately. And here we had dentists learning from nurses, midwives learning from chiropractors, like it was just totally interdisciplinary learning and respect. And that's how I base my course as well. I have gotten some slack from IBCLCs who think I should not be teaching tongue tie to people who are not IBCLCs. And I'll take that criticism, because I'm not telling them to do anything above their scope. I think everybody needs to be aware, because from what I see and the messages I get on social media, most people are not seeing an IBCLC. So we all have to be there for these families, because every baby deserves this. Every parent deserves to meet their goals. I don't say that every parent needs to breastfeed, but every parent who wants to breastfeed should reach their goals.
Oh my gosh. This episode has been so fun for me. I have learned new things. I'm sitting here cheerleading you on, and I'm so proud of the work you're doing.
Oh, thank you.
I really love it. I love this last piece about it being super interdisciplinary. And I hear you. Anyone who might find themselves in a position to provide guidance and advice can benefit from knowing more than they would ever do. It's not that you're saying, I get it. It's not that you're saying, go do this thing to somebody who is a doula. You're saying this is the conversation. This is the full extent of the conversation around this under discussed topic, right? I love it. I love it so much. I'm so excited to share these courses and resources with our clients. So all of this will be in the show notes. Lisa, thank you so much.
Oh, Tanya, thank you. I love the work you do. And I almost want to go back and have babies again, just so I can be in your program. Well, because it's so cool. The support that your clients get is the support that we all deserve. And it's just amazing.
I'll say it's pretty funny. I'm starting to have people having baby number 2. And I'm now having to think really creatively about, what does it look like to support people in this way through a second pregnancy when they already know what I'm going to say about everything? They already know my point of view. And the only thing I can think of is, they may need a little bit less, but I always talk about the speed bumps that we hit postpartum and that we don't know which ones we're going to hit. So the truth is they're very likely to hit a different set of speed bumps this time. So people are hanging out with me for baby number 2 right now. So it's getting to be pretty fun.
I mean, I learn in lactation care that sometimes my best clients are second time around moms, because we unpack what happened the first time around and can troubleshoot ahead of time and be prepared for things,
Yeah. It's so interesting watching someone who has become, an expert in their own parenting, be faced with a new baby, a new personality, new anatomy, new all the things, right? So it's like, wait, I'm so expert, but then there's all these other new things, right? It's such an interesting moment in time. Anyway, Lisa, thanks again. And I'm sure we'll have you back one day to talk about some other aspect of this that was beyond the scope of today's episode. But I think we covered exactly what needed to be covered to follow the episode that we followed. Thank you so much.
You're welcome.
Cool.
All right. Thanks so much, Tanya. Bye-bye.
Hey everyone, it's me, Tanya, your host here at the Mother Wit Podcast. You know I sometimes invite my clients on the show to talk about their birth stories and postpartum experiences, but I want to tell you a little bit more about what those clients and I actually do together. I started Mother Wit to help people in the perinatal period achieve their health and wellness goals. That means whether you're hoping to conceive and struggling with high blood pressure or high blood sugar, or you're having trouble managing anxiety or depression in the postpartum period, or maybe you just need support and advocacy between prenatal or postpartum visits, I can help. Get a discount on your first consultation with me at motherwitmaternity.com using the code FIRSTCONSULT 10% off. That's 10% symbol, all one word. I'm looking forward to working with you and maybe having you on the show too.